Everybody has a backstory. We have a persona, or you have the person that you meet, or you see them at the podium, or you meet them at a dental meeting, or you read their book, or you read a paper, you know, this or that, but you don't know what's behind that. And as I've met a lot of these people over my career in the last, 40 some years, and I got to know some of them like on a real personal level, some of their backstories are just amazing. Hygienists are so overburdened with things that they're required to do in a 1 hour appointment. That system needs to change. You can't just keep adding, we need to have you do this and do this and do this. Pretty soon you don't have time to like clean teeth. You find these particles that are about 20 nanometers in size. That's the form of the nano HA that's found in the mouth. So it's as good, if not better than fluoride at remineralization. It creates a new layer of enamel on the surface as you use it. So the FDA has actually approved using it for whitening.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 386. My name is Andrew Johnston, and thank you so much for joining me today. In today's show, I am joined by the Dr. Kim Kutsch, who is truly one of the great dental minds of our time. He's an extremely generous person as well, whose intention is to bring about an eradication of dental caries, among many other things that he wants to do. I like that he doesn't prescribe to a particular notion that it's a one-size-fits-all solution to eradicate dental caries, but that we truly need to be detectives and partner with our patients. And you'll hear that in the episode today. He also has a great book out. There's going to be a link in the show notes. Feel free to reach out and get a copy of it. It was great to read through it and get an idea of how we can use those for our patients. It is a book that is for clinicians, but also for the public, which is awesome. My plan, I think, based on this conversation and some of the conversation that he and I had on and off air, is to try and have him on with some sort of regularity. So maybe quarterly or something like that. If you have any thoughts or questions that you would like me to ask him, please shoot me an email, andrew@ataleoftwohygienists.com, and I will be sure to make sure I work that in. And then next week, we are bringing back Lisa Copeland to the show, and we talk about lots of different things, but one of the key things that we talk about is confidence and how to overcome the impulse to shy away from opportunities to speak publicly, or maybe in your group, maybe in your office as you are opening for the day, that you have a morning huddle, but you don't like doing them. And so we talk a little bit about that. We also talk about study clubs, which I know that they don't seem like they're related topics, but she is an expert in both of these things. And, study clubs for hygiene isn't something that's super popular. And so I wanted to talk to her a little bit about that and kind of what we can do as hygienists to either join an existing club or start a club or whatever we have out there. So that'll be next week. But before that, in a couple of days, I'm going to be putting out a tip episode on local anesthesia. And the reason why I'm doing that is I feel like with the House bill passing in Texas to allow local anesthesia, maybe there's some of our audience that would like a little refresher, a little brush up on it. But also there are lots of us who haven't really utilized it very much. And so this might be an episode that has some tips and tricks for them to be able to be more efficient. And also, again, going back to the Lisa thing, it's all about confidence and how can we be more confident in what we're doing. And then the last thing that I wanted to touch on real quick was a follow-up to the question about doing Botox and fillers that was on several episodes ago. I actually received an email after that episode came out from one of the companies who does the courses to teach hygienists how to deliver Botox, and they want to talk more about it. I don't know. I'm feeling pretty hesitant about accepting that offer because on the one hand, I know it's something that's really important. It's popular. Well, it's not maybe not popular, but it's coming into popularity, I would say, in many states for dentists and possibly even hygienists to start utilizing that service in their office. But on the other hand, I also keep hearing of lawsuits happening with more and more frequency as they relax the laws for who can deliver Botox and fillers and things like that. And so I'm torn because I'm not really sure if that's what you guys want to hear. So if you feel strongly about this one way or another, you think I should either accept that offer or not accept it, Again, shoot me an email, Andrew@Tale2Hygienist, and I'll put it on the list to record if this is something that you want. But that is all for me for this week. Thank you so much for listening, and enjoy this interview with Dr. Kim Kutsch.
A tale of two hygienists.
It's very addicting. There's too many amazing people in our dental world.
Oh yeah.
That, and I think yours is going to be beyond dentistry, right? That's in kind of like the format.
I've interviewed. We're going to move into like all kind of spaces, but I've interviewed some artists and a veterinarian, and I want to continue to just explore, extraordinary people and people that I've met, throughout my life experience, who I really, believe are completely extraordinary, and have an opportunity to, talk to them and, find out what makes them tick. Cause they're unusual people,
Mm-hmm.
and we all run across those people in life, and I'm always like, so how'd you get that way? Right. So, so it's been a lot of fun.
Have you always had that kind of burning desire of like, how did you get that way? Or is this something that you're like?
I think I've always been really curious, Andrew.
Mm-hmm.
One of my mentors introduced me one time, and he said, Kim is the most curious person I've ever met in my life. And so I guess that, and I love people and I love to talk, right? So it was a talent I guess I didn't know that I had, but yeah, I've always just been really curious about people. Like, what's your everybody has a backstory, right?
Mm-hmm.
Like, we have a persona, or you have the person that you meet, or you see them at the podium, or you meet them at a dental meeting, or you read their book, or you read a paper, this or that, but you don't know what's behind that, right? Like there's a person behind that, and what's their life story like? And as I've met a lot of these people over my career in the last, 40 some years, and I got to know some of them like on a real personal level, some of their backstories are just amazing. And these people are so multidimensional and have so many talents that the public isn't aware of. Like,
Mm-hmm.
they're a concert pianist, or, or they're a mountain climber, or, like Michelle's case, she's like this advocate for human trafficking. And, the list just goes on of their talents and diverse interests. And I find that really interesting,
Have you ever, and I preface this with a quick story of, I was sitting at a table one time at a dental meeting, as we do, and there was this person that's sitting across from me, and she absolutely fascinated me with her story, because not only did she do dental hygiene, but then she did dental hygiene leadership, and then she did practice management, and then she did DSO leadership, and then she kind of kept going. I'm just like, what is your end game? And it was not the right question to ask at that point. I had just met this person. So, having that kind of background, like, have you ever come across or were perceived to come across as maybe a little bit too curious or a little too blunt in your curiosity?
Oh, maybe, I don't think so. But I always tell people, particularly on the podcast, because it's recorded and we can edit it. If I ask you a question that's, makes you uncomfortable, or you don't want to answer, don't answer. I mean, you don't have to. It's been interesting to me because I've had a couple of, everybody's been very open and vulnerable. Right.
Mm-hmm.
And I've had some stories that were, like amazed me. I mean, we've sat there in tears as they're sharing some of their, their childhood stories and stuff and their background. And yeah, I mean, some of them, as some of these podcasts get produced and, we release them in the future, I mean, people are going to just be amazed by some of the stories. So I don't think so. Like I don't have a sense that I've made people uncomfortable or I've been, too curious, but I don't know. I guess I haven't had feedback. Nobody said, I haven't had that feedback yet, Andrew. So yeah.
I'll keep you, I'll tell you all the stories that I have when the time comes for that. I actually just, cause I feel like I'm a curious person as well, but I feel like I'm also a little bit socially awkward. And so I bought this book, it just came yesterday. It's called Awkward: The Science of Why We're Socially Awkward and Why That's Awesome. So I'll keep you apprised of all my stories, so you don't have to tell your own stories of why you're awkward.
They love to hear them.
So, Dr. Kutsch, I want to talk a little bit more about, I think the thing that I know about you mostly is, of course, you're, very well spoken. You're a great educator. You love your patients. You love patient education. And I think my first kind of experience, not necessarily with you personally, but it was with actually your book and about cariology. I feel like that's like the strongest thing that I know about you.
Mm-hmm.
Do you mind kind of getting into a little bit of like, why were you drawn to the study of cariology and kind of some of the facts that you're learning about?
Yeah, I'd love to talk about that. That's my favorite topic, Andrew. I think I was always, talking about that curiosity piece. I was always curious, even as a dental student. And, my parents, going back to my backstory, my parents always taught me to question stuff, right? Just don't accept stuff. Don't, think for yourself. Be able to be capable of strategic thought, be independent, think for yourself, make up your own mind, and challenge the existing paradigms. And, don't be afraid to ask why or why do we do it that way. And so in dental school, I was always kind of like, so why do we do it that way? And and the response was always, well, that's the way we've done it for the last 50 years.
Oh,
and in
gross.
my mind, and in my mind, that's like the worst possible excuse for doing it something some way is like, if you haven't found a better way to improve that treatment or outcome in the last 50 years, shame on you, right? Like you have wasted your stewardship of this profession, so you can't convince me that there hasn't been some major advancement that we could have made in the last 50 years. And so that followed me into my career then, as a clinician. And I was always looking for better outcomes, and I spent a lot of time in technology early on, lasers. I was a pioneer in lasers in dentistry. I thought maybe that would be an answer to help, and it does provide some, I think, opportunities and improved outcomes and things. But about 20 years into my career, I feel kind of stupid that it took me like 20 years to figure that out. But I woke up one morning and I just thought, what we're doing doesn't work. Like I had this epiphany that it's like I've been drilling and filling and telling my patients to brush and floss, and and they've been complying, and I've been giving them fluoride. I've been done everything I've been taught to do, and they keep getting cavities. And I practice in a small town, 50,000 people. I consider that to be a small town. Everybody has their own perspective on that, but I practice in a small town. I grew up here, and my parents, I'm like fourth, fifth generation here, farmers, blue collar community, everybody, my patients all had known me from the time I was born, right? So these are people like family and friends. And I was frustrated that here's these people I really care about, and I'm doing my absolute best for them, and they keep getting cavities. And there has to be, we're doing something wrong. We're missing a piece, right? There's something here we're missing in terms of how we treat this disease. And it was really Hien No. And I just spoke to Hien recently. He's at Perth now, but Hien's from Australia, and he has an incredible backstory. But I was speaking with Hien No. I'd spent some time. I was teaching in Australia, and Hien kept asking me this question like, Kim, how do you diagnose dental caries? And I kept talking about identifying cavities. And he was, but it's a disease. How do you diagnose the disease? And he finally got through to me, and I was like, well, I don't know. Right. And, and Hien in his own right is like a world leading expert in dental caries. And I said, well, so Hien, how do we do it? And he's like, well, I don't know either, but he goes, but we need to like diagnose and treat this like a disease. And for me, that was the missing piece. Like we've missed treating it as a whole person disease. And I came back home, and I at the next meeting I just happened to be at, Doug Young was there. He was teaching at UOP at the time. He had taken in the cariology program through John Featherstone at UCSF. John is, in my mind, probably the best cariologist, in the U.S. And so I immediately contacted John, and he mentored me. And I asked John the same question. Well, how do we do this? And he said, well, Kim, we don't know, but we just know that we should be doing it. And I was like, what? I finally get it. And you don't know how to do it? And so I told John, I'm like, okay, then I want to be a part of figuring out how do we do this, and how do we do it in clinical practice? Like John and Doug were trying to figure out how do we do this in the education setting? How do we provide this risk assessment based approach to care? How do we make this medical model work in the educational arena and in the research? And I was interested, well, how do I reduce this to clinical practice? Because I'm a clinician. I want to do this in my practice. I want my patients to stop getting cavities. And I want to be able to diagnose and treat the disease. And so that's how I really got started in this. That was over 20 some years ago. But then I really shifted away from it's not a technology that's going to provide the solution for us. It's really looking at the whole person and all their risk factors and helping them understand what's causing that disease, what's driving the cavities that they continue to get, and giving them the tools and the information to be able to get healthy on their own. And not everybody is interested in doing that, but by and large, the majority of my patients, I mean, nobody wants cavities, right?
Right.
And so that's been really successful. And then that led to, all the research I started doing, Andrew, and, I was very fortunate. I've been so fortunate. I had some of the most incredible mentors, like worldwide, because the internet was just developing at the time. And so I contacted people like Edwina Kidd in the UK and Philip Marsh there. And I mean, suddenly I had access to the best minds in the world on dental caries. And they were very open. And again, those are extraordinary people. And that's one of the traits, is they're very generous and they're very open, and they helped me so much. And then that led to, well, then I really need different products than what I've got. And I had built a number of dental companies, in my previous, career. And so I knew how to do that. And I thought, these products don't exist and they need to. And I think it was Sir Henry Royce who said, the founder of Rolls-Royce, who said, take whatever it is and make it better. And if it doesn't exist, create it. And so we were really at a point in time, I got together with Doug and I go, well, let's lay out all the science and let's design it from the ground up, let's figure out what the products should look like if we're trying to maximize our outcomes, for patients. And so that, started, Carie Free, that company. And then that led to me writing a couple of books on the topic. And the first book, Balance, was my first attempt at writing this down for patients. And I was so thick in the weeds in the science, that there was way too much science in that book. And it actually, ironically, is being used in about 135 dental schools and dental hygiene programs with the second year students as kind of a guide for, cariology. And God, there's over 300,000 copies in print of that book now. But I recognized after a couple of years, I was like, okay, I failed, right? I didn't hit the mark. And so I contacted a ghostwriter, a woman that I know, very talented. And I said, I need help. I'm not capable of being able to produce what I'm trying to create here. And so I gave her all the information, and then she helped me format it, helped me rewrite it so that it became the Why Me book, which is what I was intending to do, was a kind of a self-instructional book for patients that you could hand to a patient and say, you keep getting cavities. I'm frustrated. You're frustrated. I want you to read this book, and, I want you to highlight it, dog ear it, do whatever you need. But if you see something in there that you go, oh, that's me, bring it back and let's sit down and have a talk about that, because that's how I can help you. And so to kind of streamline, get that out of the dental operatory. I mean, hygienists are so overburdened with things that they're required to do in a 1 hour appointment. Like, that system needs to change. Like, you can't just keep adding, we need to have you do this and do this and do this. Pretty soon you don't have time to clean teeth, right? You can't, and I don't have an answer for that. I just know that the more of those things that we can take out of that to streamline the process, the better for everybody, right? And so that book, gives us an opportunity to give that to the patient and let them do some work on their own. And the wellness coaching aspect is, the work belongs on the patient's shoulders, not your shoulders or my shoulders. And now the book is being translated. We're translating it into Spanish.
Nice.
So, I mean, I've had so many people request, I've got all these Spanish speaking patients. Can I get this in Spanish? And I'm like, wow, I hadn't thought about that. And yeah, that's a great idea. So it's won 3 nonfictions awards. And so I'm pretty happy, pretty pleased with it. I kind of hit the mark finally, but I had help, right?
Sure. I think you should be proud about that. Do you mind if I ask this? So, in 20 years ago, when you guys were building out the framework for trying to help figure out how to get this into the clinics and make it usable, I feel like the risk factors as we knew it back then were maybe a little more simplistic than what they are today. So do you mind kind of going over that kind of the evolution of what risk factors were important and what risk factors are we now considering to be more important for Caries risk that maybe even 10 years ago we weren't really looking at?
Oh, the risk factors haven't changed a whole lot, Andrew. That's a really great question. And I would tell you that I failed miserably trying to get this started in my own practice. I mean, if there was a mistake that could be made, I made it. And one of the challenges that we had, I was in the first Canberra group, and that was with, John Featherstone and Doug Young and I. And then I think there was, 10 or 11 of us, and they were all either educators or researchers. And then I was kind of like the black sheep, this lone clinician who was trying to sort this out. And our early work that we published in 2003 in the California Dental Journal, I look at it now and it's like, it's no wonder we took something and made it even yet more complicated, right? and we knew that dentists and hygienists weren't all great communicators, so we created this form letter and that had 19 separate bullet points on what the patient needed to do now. And after spending 2 years in a wellness coaching program, we suck at making change as humans. And even trying to change one thing is like a huge hurdle. Trying to change 19 all at once. I mean, I look at that now and just laugh, but it's why it failed miserably. The risk factor form was way too complicated, had way too many questions. It was in a survey type thing, and it was an interview that happened in the hygiene operatory. Well, hygienists don't have time to do that. You don't have an extra 10 minutes to sit and interview somebody about their, Caries risk factors. And so one of the things that my team and I did, and so that didn't work in my practice. And I got really frustrated, and my patients were frustrated, my hygienists were frustrated with me because I was frustrated with them. And we finally kind of had a breakthrough on my team. We simplified the form. We collected data on over 12,000 patients of 6 different practices. We, collated the data, and the number one risk factor based on self-reported risk from the patients. And self-reported is a real important key here because that was a game changer. And I'll explain that in just a second. But number one was saliva. So 70% of the, patients have a salivary issue. They either, don't have enough saliva, or they're taking medications that are causing, hyposalivation. Number 2 is diet. And, Americans, we're off the charts on how much sugar we consume, right? And so you can just assume your patient is eating too much sugar, or they're eating too frequently. We don't sit down and have 3 separate meals anymore. We graze. People eat all day long, or they sip all day long on a sugar sweetened beverage. Well, that's a recipe for dental caries. And then the biofilm itself. And we've made a lot of progress in understanding the different players in the biofilm. But, when I started looking at this over 20 years ago, it was mutans, streptococci, and lactobacillus, and that was it. We were all taught that. And it turns out, well, it's so much bigger than that. And 40% of the children in the United States, adolescents, 40% that have severe early childhood caries have 0 mutans, streptococci in their mouth. They don't have that bug. And so we always thought that was the smoking gun and the causative agent, and here almost half the kids don't even have it, so now we understand years later that, Candida, which we thought was just kind of, there because it was acidic anyway, we understand that is now a major player. And then we really got to a point of understanding through a lot of Philip Marsh's work that doesn't matter who's there. Doesn't matter.
Yeah.
In fact, Takahashi and Neved back in, I think, 2009 published some research that indicated like Strep gordonii was like the gold standard for the healthy commensal bacteria. So as I was doing checkerboarding and studying at Forsyth, we were looking for that as the outcome, right? We got rid of, the mutans, streptococci, and look, we increased the levels of Strep gordonii. So the patient's healthy. Woohoo, we've had success. And what they demonstrated that year was that Strep gordonii, within 30 minutes of being in an acidic biofilm, joins the party, and they're indistinguishable from Strep mutans. So it's like, well, it's either that or die, right? And so they're very good at adaptive. They have the same adaptive mechanisms. And so then it really doesn't matter who's there. This whole idea of good bugs, bad bugs isn't as important as what's the overall output of the biofilm itself. Is it producing acid? If it is, and you're out of balance, throughout the D-min-Riemann cycle, the Stefan curve through the day, you got dental caries. And if it's not producing acid, you don't. And it's as simple as that. So now it really doesn't matter which microbes are there. There are still microbes. I mean, mutant streptococci, lactobacillus, yep, they still play a role in the disease at the population level. Are they indicative of the disease? Are they somewhat predictive? Yes, but not totally predictive and totally don't explain the disease. But those are the three biggest risk factors. So us putting that into a simplified risk assessment form, having the patient self-report it so the hygienist doesn't have to sit and ask those questions.
Mm-hmm.
And then that changed the entire psychology of that relationship as well. So if you've ever had the experience of telling a patient, oh, it looks like you have a dry mouth, and the patient says, no, I don't. And well, do you ever feel, no, you're done, right?
Right.
You are not going to convince somebody that they have something that they don't perceive they have. That's a waste of time.
Yeah.
And we beat our heads against that wall forever, right? But that doesn't work. And when a patient says, oh, I have a dry mouth, and they self-identify it, now that's a whole different relationship. Now they expect you to talk about it, right? So it's not you telling them something they don't think they have. They're telling you they have something, and they're expecting you to have some kind of solution for it, or at least to be able to sit and talk about it. So it took all of that time constraint out of the hygiene operatory, and then it also changed the nature of the relationship by having them self-report their risk factors. And so we tried to simplify it into those three kind of main categories. Genetics plays a role about 9% on a population level. On an individual level, that varies person to person, right?
Sure.
And we've identified over 50 genes at this point in time that increase your risk for dental caries, but we really don't have the tools to assess that right at the moment. So, so I just look at saliva, diet, and biofilm as kind of the three biggies. And so focusing, I think, on, those main contributing risk factors has simplified it and made it a lot more successful and easy to integrate into, just daily practice. And that's made it successful.
I think, the patient definitely has an onus to do, home care still, to the best of their ability. But, sometimes, based on the risk factors, they do need additional help. And you mentioned about products earlier, and we don't have to get into very specific ones unless you want to. But, for every one of the risk levels, or for like low caries risk versus high caries risk, what are some recommendations that we need to be giving to our patients to kind of help them improve their overall risk factors?
Yeah. So looking at my own practice, Andrew, so once a year and always you're getting a risk assessment form to fill out once a year, because
Sure.
risk factors change over time. You start taking a medication or change medications, or you change your diet, something like that changes in your life. I need to know about that. If I'm going to be able to help you prevent this disease, I need to know ahead of time. I don't want to be treating it downstream afterwards. I want to be upstream. And so that's an important way to begin with that. So yeah, so number one always was a risk assessment, every year. Then my low risk patients, which is probably 10% or less in the practice, which means they don't have any risk factors and they don't have any signs of the disease. Then I see them like once a year, and then I recommend, fluoride varnish. I recommend, or I offer that to them. I offer, a product that has, that has an alkaline pH, has fluoride, nano HA, it's saturated with xylitol, the benefits that we can get out of these products. So I offer that to them. For my moderate risk patients, these are people that have at least one risk factor but don't have cavities, don't have signs of the disease. I'm going to see them twice a year. And I'm going to recommend fluoride varnish like twice a year when they're in. I'm going to recommend probably putting them on a 5,000 part per million fluoride gel, dentifrice gel that again has nano HA in it. And that's another topic, the nano HA, xylitol, fluoride, and pH. pH is a big part of that equation as well. And then for the patient that has the disease, if they have a biofilm issue that we've identified, I'm going to probably put them on an antimicrobial rinse. For that, I'm going to use the Caries-free treatment rinse, and it has sodium hypochlorite in it. And that's another topic. There are so-called experts out in our profession advocating that all antimicrobial rinses cause, increased systolic blood pressure, reduce the nitrite, nitric oxide pathway, and that doesn't happen to be true, so that's another hot topic of mine. And I'm going to recommend that. Then I may or may not use silver diamine fluoride on that patient, depending upon where the lesions are located and their acceptance of that, because obviously it's going to turn those lesions black.
Mm-hmm.
And so that's something that I'm going to, utilize as well. And then I'm going to address the risk factors and sit and, talk about, so how do we address that? How can you get healthy? What kind of ideas do you have? And I kind of co-coach people as well. A lot of times it's sugar sweetened beverages. A lot of times it's medications that they're taking. It's how frequently they're eating. I mean, just being able to sit down and help them identify, and again, give them the Why Me book, and let's have a conversation. Go read this and let's have a conversation about that. And then let me if you can't come up with some ideas on your own, let me give you some ideas on how this worked for other patients that had the same issue and what they did and what was successful for them. So, and then, your cell phone, it's like, we know that establishing a new habit, if it's a home care thing or you're trying to change a dietary habit or whatever, we know that a new habit, a sustainable new habit, takes upwards of 9 months to create, and it needs literally daily reminders. And so, here's the best, I'm not going to stand in your bathroom next to you and remind you to floss every morning. I don't get paid to do that, but I use this, set a reminder, and show the patient, just take a lot of your patients aren't aware of all the capabilities of this thing. It's a phone and a camera, and it's how they access their, social media or whatever, but it's a great tool for helping a patient create new habits as well. So, so that's kind of my protocols for those patients.
I love it. Doctor, I'm going to probably have a whole nother episode on the mouth rinses. And then, Michelle actually told me specifically, like, you need to ask them about the mouth rinses, the nitric acid and all this kind of stuff. So probably have to come back to that one, but I do probably want to end on nano HA. You said that was another topic that we should probably go into. Like, tell us what your thoughts are on it.
Okay. So that could be a single episode in itself, but let me just kind of go through it quickly. Nano HA is found in the saliva. Like, our saliva is super saturated with nanoparticles of HA. Mm-hmm. And as we eat and you stimulate saliva flow, that degree of supersaturation increases. So your body we have teeth because they are bathed 24/7 in a supersaturated solution of the mineral that they're made of, right? And if we didn't have that, we literally wouldn't have teeth. So that nano HA particle in the mouth, so the building blocks of the teeth, the enamel, is about 20 nanometers in size. They're kind of like little Lego blocks. And so our whole understanding I studied this for a couple of years, of demineralization and remineralization, it's not an ionic phenomenon. It's actually little chunks of enamel come out and then they go back in, and they're about 20 nanometers in average size. And lo and behold, not surprisingly, that's exactly what we're finding in the saliva. You find these particles that are about 20 nanometers in size. That's the form of the nano HA that's found in the mouth. So it's as good, if not better, than fluoride at remineralization. It creates a new layer of enamel on the surface as you use it. So the FDA has actually approved using it for whitening. They allow, people companies with nano HA to make a claim that it's a whitening product. And it also reduces the biofilm buildup in the mouth as well on the teeth. And so it serves all of those functions. Now the challenge becomes that 20 nanometer spherical shaped nano HA is very expensive. I mean, we have that in all the Caries-free products we put in there, I think in 2010. And it's the most expensive ingredient. It's very expensive. And just in the last couple of years, there's a lot of quote unquote nano HA coming out of China that's up to 200 nanometers in size. And a lot of that material is needle shaped. It's not spherical, it's needle shaped. Now, does that work? Yes, it does. It doesn't matter what the concentration is. The studies indicate, looking at whether you have 2%, 5%, or 10%, and the studies that have been done, the outcome was there was no statistical difference. Like 2% is adequate. 10% is not an advantage based on the science. The needle-shaped thing will work. It does remineralize, not as successfully as the 20 nanometer does. If you look at the research, that's the most optimum, and it shouldn't be surprising because that's biomimetic. I mean, that's what's happening in your body right now. But those needle-shaped nano HA particles have now been banned in Europe because of the health risk of them penetrating soft tissue. So they're inexpensive. They're quite inexpensive. We've been approached by a number of companies from China just saying, oh, yeah, we have this product. And we look and go, no, that's not it. We're not using that. But that Europe just last fall banned all nanoparticles of HA, all. It doesn't matter what shape, because they just, they can't figure out, can't regulate it that way. So they just banned them entirely last September, which is unfortunate because the spherical shaped are safe. That's what's in your saliva. So concentration doesn't matter. Size does matter. Shape matters. And nano HA is not all, it isn't like nano HA is nano HA. There are differences. And so, consumers and, our profession need to be aware of that and be able to distinguish, well, your product says it has this, what shape are they? And, and what size are the particles? So that's kind of an important part of that in a nutshell.
I mean, I feel like we could go into it a little bit deeper too. Cause I feel like it's all the rage now. Like, you see it everywhere. Everyone's marketing it, but it's, I think it bears some consideration of like, what product is it exactly? I think it's too broad of a claim. Doctor, I can't tell you how much I love the format of your podcast. Ours is a little bit shorter, so unfortunately this is going to be the end of it. But if someone wanted to check out your podcast, the books, reach out to you, like, how can they find you?
Okay. So real quick, Contrary to Ordinary is the title of the podcast. It's on every podcast platform, and I am blown away by how well it's doing. It shouldn't be, I guess, shocking, but I think the internet and social media is so full of hypercriticism and negativity that hearing some positive, inspirational human stories, I think we're all hungry for that. So you can find it anywhere, Contrary to Ordinary. Just go search that, and please download and subscribe. If you want a copy of the book, you can contact Carefree, carefree.com, and just go to the website or call the company, and they'll send you a copy of the book for free. And if you want to contact me, it's kimkutsch@aol.com. And so that's KIMKUTSCH@AOL.com. And probably the best way to get in touch with me is just through my email address.
Thank you so very much for being on today. I really, really appreciate it.
Oh, Andrew, I had a great time. I look forward to talking to you again and sharing some more stories.
Absolutely.
All right. Thanks, Andrew. You have a great day.
You too.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.